Welcome to the Deep Dive, where we transform complex research into actionable knowledge, custom-tailored for you.
It's great to be digging into this today.
Absolutely. Today, we've got a monumental stack of sources articles on national planning, health financing, even emerging biological threats.
Yeah, quite the pile.
And we're using them to execute a really crucial mission, diving deep into evidence suggesting India's powerful political narrative, the one about future economic greatness.
The 2047 vision, yeah.
Exactly. That it's actually masking a profound, silent collapse in foundational public health.
And look, this isn't just about budgets being a bit tight. It's presented in these sources as a systemic failure. We're looking at how decades of, political short-termism.
Kicking the can down the road.
Pretty much. That, combined with chronic underfunding and a really aggressive commercialization of medicine, has built a system that fundamentally seems to prioritize financial return on investment over, frankly, patient survival.
That's a stark assessment.
It is. And if these sources are right, this broken foundation is the perfect incubator for a looming health catastrophe. Antimicrobial resistance, or AMR.
Right, the superbugs.
Exactly. Which now threatens to violently derail the very economic dreams the nation keeps talking about.
So that's the core conflict we need to unpack today. Our deep dive is focused on synthesizing this evidence. How have foundational health metrics actually failed? Why was systematic planning sort of abandoned?
Tossed aside, yeah.
And critically, how have financial incentives maybe warped the role of the caregiver, turning them into something more like a high-pressure salesperson?
That's the crux of it. We need to follow the evidence trail that suggests why, for India, focusing only on financial health while letting human health slide. Well, why that might be a strategy doomed to fail.
Okay, so let's start there. Let's contrast that political dream with the current reality our sources are painting.
Right. The political machine, it constantly speaks in terms of this huge future success, doesn't it? The slogans promise India will be the world's largest economy in 2047.
You hear it all the time. It's the narrative of an emerging superpower demanding global respect.
But then you look at the raw economic data on, individual well-being, and the contradiction is, it's pretty stark.
Dizzying is a word that comes to mind. While the country might boast, the fourth or fifth largest overall economy, the real measure of how citizens are doing per capita income tells a totally different story.
Totally different. The sources peg that figure at an alarmingly low $2,878.
$2,800 per person.
Yeah. And that puts India 142nd out of 193 economies globally.
142nd? That doesn't exactly scream superpower in waiting.
It really doesn't. Think about the implication of being ranked that low. It's just not the profile you'd expect for a nation supposedly on track for 2047 dominance.
And the reality check comes from basic needs, right? Like food.
Precisely. Even now, heading into 2025, the government still needs to provide free rations to around 800 million Indians. 800 million.
That number just underscores the vast gap, doesn't it, between the proclaimed national greatness and the fundamental struggle for basic survival faced by a huge portion of the population.
Majority, really.
So how did the system develop this kind of blind spot for foundational needs? The sources seem to trace it back to abandoning institutional discipline, long-term planning.
Yeah, and it's a failure that the sources suggest spans multiple regimes. It's not just one administration. But it certainly culminated, or perhaps accelerated, with a key institutional shift. Looking back, leaders since, the post-Nehru era often seem to sideline basic protective health care.
In favor of?
Grant projects, maybe other kinds of spending. There was just this consistent failure, it seems, to invest robustly in public health structures over the long haul.
And then came a more recent, very specific change.
Right. That institutional neglect really picked up speed when the Modi administration abolished the Planning Commission back in 2014.
Which was a big deal, institutionally speaking.
Huge. It was replaced by Niti Aayog. Now, Niti Aayog is a sophisticated think tank, no doubt about it. But crucially, it lacks the statutory power and, importantly, the budgeting role its predecessor had.
So it can think, but it can't really do in the same way.
Exactly. The old commission had the power to allocate funds, to actually direct implementation to states. It provided a central mechanism for long-term planning, especially in areas like health and education.
And without that power, that oversight, what happened?
Well, governance seems to have shifted. One source calls it a series of impulsive experiments.
Impulsive experiments, like...
Well, the big ones stand out. The 2016 demonetization, for instance, estimated to have cost the nation about 1.5% of its GDP.
Which is massive.
It is. And then, even more famously, the 2020 national lockdown,
Yeah.
announced with just 4 hours' notice.
I remember that. Chaos.
Absolute chaos. It resulted in a devastating minus 24% GDP plummet in that quarter and triggered that awful humanitarian crisis for migrant workers trying to get home.
So the sources are arguing these policy failures are a direct result of losing that planning function, that feedback loop.
That's the argument, yeah. We can think about it using the Plan-to-Check-Act cycle, PDCA. It's the bedrock of quality control, continuous improvement for any successful organization, or nation for that matter.
Like Japan, Germany, they built this into their systems, right?
Exactly. They institutionalized PDCA into their national planning. It ensures stability, allows for learning, promotes long-term growth.
But in the Indian context, the sources say this cycle is just broken.
Completely broken down, according to the analysis. The plan stage gets reduced to just a slogan, a grand announcement. We'll be number one by 2047.
Right. The does state happens often impulsively, maybe driven by immediate political needs.
Check. Then the check step, systematically measuring outcomes, gathering reliable data, doing proper impact studies.
That's the part that's missing.
Either missing, or the data is actively hidden, or it's just not done thoroughly.
So if you can't check, you can't learn.
Precisely. Which means the act stage, the course correction, it only seems to happen when things boil over, when political protests get so big, so disruptive, that the government is forced to react.
And this short-termism, this lack of a feedback loop, directly leads to neglecting public health.
That's the connection the sources make. Why? Because the really bad effects of poor health funding, rising death rates, drug resistance emerging, they often don't become glaringly obvious for a decade, maybe two.
By which time?
By which time the politicians who made those cuts are often out of office, or they're focused on the next election cycle, not the consequences of the last one.
So the sources suggest policymakers know the long-term damage.
They suggest awareness exists, yes. But the political imperative capturing power, making hay while in power, as one source puts it, that short-term thinking dominates.
And you see this in the budgets.
Starkly. Whenever the government needs money urgently for whatever crisis, the first budgets to get squeezed are almost always health and education. Consistently.
And there's that inverse relationship mentioned.
Yeah. One source highlights a persistent historical pattern. Defense spending often goes up when healthcare spending goes down, and vice versa.
So, across decades, leaders have basically protected a system that prioritizes immediate gains, whether security or big projects, over the long-term health of the population.
That's the picture painted. Sacrificing that foundational public welfare becomes a pattern.
Okay, let's pivot now from the sort of political philosophy, the planning aspect, to the actual physical result of this neglect, the state of the public healthcare system itself.
Right, the broken foundation. And the numbers on health financing really tell a story. They demonstrate just how low a priority human life seems to be compared to, say, financial returns.
The spending figures are alarming.
They really are. Public expenditure on health, the government spending, was recorded way back in 2008-09 at just 1.10% of GDP. 1.1%.
That's incredibly low on an international scale.
It is. Even more, current estimates put government spending at only around 2% of the total budget. Compare that to 15% in many developed countries.
15% versus maybe 2%, that's a chasm.
A massive deficit. And guess who picks up the slack?
The average person.
Exactly. It gets offloaded immediately onto citizens. This leads directly to that crushing out-of-pocket, or OOP, burden we hear about.
Because the public system just isn't there or isn't enough.
Precisely. So private households end up accounting for more than 3/4, over 75% of all health spending in the country.
3/4 out of pocket.
And the sources estimate this OOP spending was around 71.1% back in the late 2000s. This isn't just an inconvenience. This financial shock pushes roughly 39 million Indians into poverty every single year.
39 million annually, just from healthcare costs.
Just from trying to get well or keep a family member alive, it creates this impossible choice for vulnerable families.
Accept treatment and go bankrupt, or refuse care.
That's the dilemma. Risk death or permanent disability, or bankrupt the entire family. Well, the sources frame it as a kind of ethical and financial violence inflicted on the poorest. A predictable outcome, they argue, of protecting a system that values financial returns above all else.
And the state of the actual public hospitals reflects this neglect.
Deeply. Descriptions in the source material paint a picture of, quote, dire straits.
What does that mean specifically?
We're talking about wards with inadequate equipment, or it's broken,
Mm.
or it's just absent. Unclean wards, filthy toilets, patients literally lying on floors because there aren't enough beds, or the equipment needed isn't functional.
Even for more advanced care.
Especially for high-tech care. That often requires imported equipment, which gets incredibly expensive, particularly when the rupee devalues.
Which it often does.
Right. So to try and cover the maintenance costs of this expensive imported tech, many public hospitals actually feel forced to charge user fees.
User fees in a public hospital.
That's the tragic irony, isn't it? A public hospital, supposedly there to serve the poor, ends up putting up financial barriers that the very people it's meant to serve avoid, purely out of fear of bankrupting their family.
This must just crush morale for the staff.
Fundamentally, the doctors, the nurses in these public systems, they're working for poor salaries, often in terrible conditions. The sources mention them having to personally arrange financial help for patients sometimes.
The doctors themselves.
Yes. Or even astonishingly, trying to repair broken machines themselves just to keep basic services running. It feels like a system designed to punish dedication, to drive talented people towards the private sector where the money is. And beyond the existing staff, there's the broader human resource challenge, right? Not enough people, maybe not the right skills.
A huge challenge. India struggles with inadequate levels of staff, the right skill mix, the quality, and crucially, the distribution.
Distribution meaning where the staff are located.
Exactly. The problem is especially bad in rural areas. Over 70% of India's population is rural. Yet, the number of government hospital beds in urban areas is more than double the number in rural regions. So the care is concentrated where fewer people live.
Dramatically so. It perfectly illustrates that concept called the inverse care law,
Which states
that those with the greatest need for care, the rural poor, the financially vulnerable, are the very people who have the greatest difficulty accessing any reliable services. They have to travel longer distances, which just adds to their out-of-pocket costs.
And the shortage in rural areas, it creates a vacuum.
A massive vacuum. And it often gets filled by informal or uncertified practitioners, sometimes called quacks.
How many are we talking about?
The sources suggest it could be over 1 million practitioners in rural India who may not be formally trained or licensed.
1 million. That's staggering. And critical for the AMR issue we mentioned earlier.
Absolutely critical. Because these informal providers often dispense antibiotics freely, over the counter, with no prescription, no diagnosis. They completely bypass any kind of formal control or stewardship.
And the pipeline for trained staff is also flawed. You mentioned cost.
Flawed from the start, largely due to economic barriers. The cost of medical education is just astronomical. Getting into medical school often requires huge amounts spent on private coaching classes.
Coaching classes that cost.
More than the average Indian citizen's annual income, in many cases.
It's effectively gate-kept by wealth.
That's what the sources imply. This financial gatekeeping ensures that the healthcare workforce that eventually emerges isn't really representative of the population it's supposed to serve.
And the debt pushes them away from needed areas.
High educational debt naturally pressures these new doctors. They're pushed away from essential high-need areas like primary care, especially in rural settings, towards higher-paying specializations, almost always in urban centers.
So the system itself reinforces the inequity.
It seems designed to protect the interests of the affluent, ensuring the highly trained workforce serves financial centers over public health needs, solidifying that urban-rural divide. Okay, so if Section 2 showed us the broken foundation of the public system, Section 3 really explains the economic engine driving the high-end private sector.
And the philosophy there is different.
Entirely different, according to these analyses. It's centered completely on maximizing return on investment, ROI. This, the sources argue, is the origin of prioritizing doctor-centered care, or perhaps hospital finance-centered care, over patient-centered care.
Let's break down that financial pressure cooker you mentioned, the high capital trap.
Right. Building a major hospital, especially in a prime urban location, it's a massive financial undertaking.
How massive?
Sources indicate that building, say, a 500-bed hospital, requires roughly 1,000 crore rupees in capital expenditure. That's huge. And it's almost entirely funded by debt.
1 billion rupees, mostly borrowed.
Exactly. And once that enormous investment is made, the debt clock starts ticking loudly. From that moment, the hospital isn't just a place of healing anymore. It's also a financial institution that must prioritize generating revenue.
To pay back the loans and satisfy investors?
Precisely. Servicing the debt, achieving shareholder return, that becomes paramount. The pressure to keep beds filled, to keep surgery scheduled, it becomes almost an existential requirement for the hospital's survival.
And this is where the doctor's role gets warped.
This is the critical juncture. To recover that massive capital outlay, hospitals start acquiring doctors not just for their medical skill, but also because they're expected to bring in patients. Patients who are now viewed, essentially, as high-value customers.
So doctors become revenue streams.
In effect, performance metrics get imposed. And these metrics often focus heavily on conversion rates.
Conversion rates, meaning?
Meaning how many initial consultations ultimately convert into high-revenue procedures. Things like surgeries, complex diagnostic tests, extended admissions. And this leads directly to what the sources call the perverse commission model.
Okay, explain that.
Hospitals often pay doctors based on a fee-for-service structure or, more directly, a percentage commission on the revenue they personally generate.
A commission, like a sales job.
Exactly like a sales job. It could be up to 20%, sometimes more. So if a doctor performs a surgery that bills for, say, 1 lakh rupees.
They might get 20,000 rupees personally.
Correct. And in really competitive markets or where hospitals are under immense debt pressure, doctors might even face minimum guarantee recovery targets.
Minimum guarantee recovery.
What's that? It means the doctor must generate a certain minimum amount of revenue for the hospital each month, regardless of the actual organic medical needs of the patients walking through the door.
That sounds ethically challenging.
It forces them to act like salesmen. They might feel compelled, potentially against their pure medical judgment, to recommend more tests, more procedures, longer stays, just to ensure they hit those financial targets and keep their position.
And the immediate consequence for the patient is?
Rampant overbilling and critically unnecessary procedures. That's the strong suggestion in these sources.
Can you give an example?
Sure. A complex procedure, like a knee replacement. Maybe the standard fair cost should be around 2.5 lakh rupees. Suddenly, the bill balloons to 4 lakh rupees.
How do they justify that jump?
Well, the sources note the explanations given are often vague or impossible for a patient to verify. Things like additional high-end supplies were needed, or unexpected complexity, or premium surgeon fees. Patients are vulnerable, often medically illiterate. They just can't argue.
It sounds like the hospital basically outsources its sales targets directly onto the doctors?
That's a good way to put it. The caregiver becomes the sales closer, and this core contradiction shows up even in just basic hospital operations.
How so?
Well, that high capital expenditure, the need to maximize revenue from the physical space, means optimizing for maximum bed capacity. Often, this completely overrides considerations for basic patient experience or operational efficiency.
Like long waits, confusing bills.
Exactly. The system is so hyper-focused on high revenue throughput, paying patients in and out, that it fails to invest in basic things like process engineers, people who could actually fix the fragmented billing systems, or the agonizingly long wait times, or the inefficient discharge protocols that drive patients crazy.
Instead of fixing the process, they pressure the doctors.
Yes. They pressure the doctors, the most highly skilled, most expensive human resource they have, to somehow optimize sales targets, instead of focusing purely on care.
The sources also mention the arbitrariness of pricing.
Oh, absolutely. Why should an X-ray of your leg cost significantly different than an X-ray of your chest? Why does a very senior surgeon charge dramatically more for a procedure, even if their superior skill means they actually use less operating theater time?
There's no patient-centric logic there.
None whatsoever. The only logic seems to be maximizing the charge based on what they think the patient or their insurance can bear. It creates a system where the patient is completely at the mercy of the profit motive.
So pulling this together, the argument is that leaders, maybe over decades, have either failed to provide basic protective health care in the public sphere,
Right, through neglect and underfunding.
or in the current private system, they're actively protecting a model that gives absolute priority to financial ROI.
That's the core argument. The failure lies in upholding this doctor-centered or hospital finance-centered business model, ensuring that the financial health of the institutions consistently trumps the human health of the nation's people.
Which brings us directly to the potential catastrophe looming over this whole system, antimicrobial resistance. AMR.
The time bomb, yes. Because this profit-driven, underregulated, often chaotic health system, both public and private, has created the perfect storm for superbugs to thrive.
And India's role in this global crisis is significant.
Alarming, according to the data. India has one of the world's highest rates of antibiotic consumption. Usage apparently increased by a shocking 48% just between 2010 and 2020.
Nearly 50% increase in a decade.
Yes. And AMR is insidious, you know. It leads to deadly healthcare-associated infections, infections people pick up in the hospital. It makes drugs that used to be lifesavers completely ineffective.
And drives up costs even further.
Ironically, yes, exponentially. It leads to longer hospital stays, more expensive treatments needed, higher mortality rates.
So if the nation keeps prioritizing the financial health of hospitals over the actual health of the public,
Then the sources strongly suggest this AMR crisis could be the thing that finally breaks the system. It could be the infection that kills the goose laying the golden eggs.
meaning it undermines the economy itself.
Exactly. It sickens the workforce, kills consumers.
Yeah.
The very people needed for that economic growth everyone talks about.
Yeah.
It could potentially bankrupt the nation in the long run. That vision Mr. Modi often speaks of, becoming the wealthiest nation. Well, the sources imply it could just become another slogan with no weight if AMR isn't tackled.
So what's driving this massive overuse and misuse of antibiotics?
It's complex, systemic, multiple factors feeding into each other. First, there's simple patient demand.
People asking for antibiotics.
Aggressively, sometimes. Many patients mistakenly believe antibiotics are the necessary standard of care for almost everything. They want a cure, and they want it as fast as possible.
And doctors feel pressured to prescribe them.
They do, especially in the private sector, with intense market competition. They fear losing patients' customers to a competitor down the street if they don't give the patient the good treatment they expect, which often means antibiotics, even for viral infections where they do nothing.
Okay, so patient demand is one factor. What about physician factors?
Several things. Doctors often have to resort to empiric treatment, meaning they make an educated guess about which antibiotic might work because they lack access to rapid, sophisticated diagnostic tests to actually identify the bacteria and its sensitivities. This is especially true in smaller clinics or public hospitals.
So they use broader spectrum drugs just in case.
Often, yes. Then there's fear of litigation. If a patient comes back with a recurring infection, which might be due to poor hygiene or living conditions totally outside the doctor's control, the doctor could still face legal action.
So prescribing a powerful antibiotic up front becomes a defensive measure.
It can be perceived that way, a way to show they did everything possible, even if it wasn't clinically optimal.
And then there are the commercial pressures we discuss.
Relentless commercial pressures.
Yeah.
Direct promotional activities by pharmaceutical companies heavily influence prescribing habits. Pharma reps visiting doctors, offering incentives.
And antibiotics are profitable for hospitals.
Hugely profitable, especially the newer, more expensive broad-spectrum ones. They're a major source of income, particularly for smaller hospitals and clinics that rely heavily on medicine margins to stay afloat. The incentive is to sell more and more expensive drugs.
So with all these pressures, trying to implement control measures must be incredibly difficult, like antimicrobial stewardship, AMS programs.
Extremely difficult. AMS programs are basically structured activities designed to promote rational antibiotic use within hospitals. Good idea in theory.
But in practice?
The sources detail a study looking at AMS implementation in secondary hospitals in Kerala, and the results were, well, disappointing.
They didn't work.
They failed to show a significant clinical impact. For example, they couldn't significantly reduce the total days of therapy for common things like upper respiratory infections, where antibiotics are often useless anyway. Nor could they significantly increase the practice of de-escalation, that's switching from a broad-spectrum antibiotic to a more targeted, narrower one once culture results are back.
Why did it fail? What were the barriers?
The study identified numerous structural obstacles. Intense competition among doctors within the same hospital. Just sheer time constraints, doctors are overworked. Lack of a clear champion for AMS among the hospital administration. Poor cooperation between different departments.
And data problems again.
A critical data point, yes. AMS really depends on having accurate, reliable data, specifically antibiograms.
Those charts showing local bug resistance patterns.
Exactly. But the sources indicate these charts are often unreliable. Why? Because bacterial cultures are typically only sent to the lab when the patient is already very sick and often already receiving high-end, powerful antibiotics.
So the sample is biased from the start.
Completely biased. A clinician in one source noted, if the patient is already on drug X, the culture will likely only show bugs sensitive to even stronger drugs, drug Y or Z. This forces the doctor into a cycle of prescribing ever more expensive, ever more powerful drugs based on skewed data. It actually accelerates resistance rather than controlling it.
That's perverse. And there was a supply paradox mentioned too.
Yeah, another sign of systemic failure. Essential, often older, preventative antibiotics like cefazolin, which is recommended for preventing infection during surgery, might actually be unavailable through the normal, legitimate hospital supply chains.
Needed drug isn't there.
Might not be. Yet paradoxically, the high-end last resort antibiotics, the ones that really need to be preserved and used carefully, can also be procured easily through, quote, alternative methods with doubtful legality.
So the black market or gray market fills the gap for the restricted drugs, while basic needed ones are missing.
It points to a total regulatory and ethical breakdown. The system seems rigged for profit and misuse, while rational, disciplined prevention is actively obstructed.
Okay, this paints a pretty grim picture. If the core problem, as these sources argue, is this high capex, debt-driven model that forces sales pressure onto doctors, what's the alternative? How do you disrupt that?
Well, the sources are clear that the solution requires a pretty radical disruption of that underlying financial structure. It's not just about tinkering around the edges.
So what does a disruptive model look like? The source material mentioned one example, superhealth.
Yes, that was highlighted as an alternative approach, and its core difference is how it attacks the incentive structure directly. Instead of that commission model or fee-for-service based on volume, they prioritize fixed, competitive salaries for their doctors.
So taking the sales pressure completely off the table.
Exactly. Removing the minimum guarantee recovery targets, removing the percentage cuts. The doctor's income is stable, not tied to how many procedures they order or how much revenue they generate.
And what's the result of that shift?
It leads to a fundamental structural transformation in how they operate. With sales targets gone, Superhealth's only metric becomes quality patient care. That's the focus.
And they operate differently. Smaller scale?
Yes, often on a deliberately limited bed capacity, maybe 50 beds instead of a giant 500-bed complex. They focus intensely on operational efficiency.
Which leads to?
0 wait times, apparently. And a focus on discharging patients promptly and safely as soon as medically appropriate. They essentially absorb the complexity and cost internally by designing processes that eliminate unnecessary steps, unnecessary procedures. The patient just focuses on getting better.
That sounds revolutionary almost compared to the system we've been describing.
It's a different philosophy. Another key disruptor highlighted is the potential of home health care.
Bringing care to the patient's home.
Precisely. This shifts services away from that expensive, centralized, high-capex hospital infrastructure altogether.
And the cost savings are significant.
Enormous, according to the data cited. Sources estimate home health care can cost almost 1/3 less than an equivalent hospital visit or stay. We're talking potentially thousands of dollars saved per day for complex care.
And home care isn't just basic nursing anymore, right?
Not at all. Due to huge advances in telemedicine, mobile diagnostics, portable equipment, the scope of home health now includes things like blood draws, IV infusions, sophisticated monitoring, even specialized treatments like chemotherapy.
So it can genuinely substitute for some hospital care.
It can. And this decentralized approach is vital because it offers a practical way to bypass those crushing capital expenditures and the profit centralization issues that seem to plague the current hospital-centric system.
So specific models like superhealth and broader trends like home health care. These offer alternatives. But what about the systemic planning failure we started with?
Fundamentally, the sources call for a return to that institutional discipline, reestablishing the Plan-Do-Check Act framework at the national policy level.
Bringing back that structured approach.
Yes, mandating systematic practices that allow for continuous improvement, setting clear goals, having validation checkpoints, conducting regular retrospectives, and actually learning from them. It's about rebuilding the very structural discipline that eroded, particularly after the Planning Commission was abolished.
And this needs to be backed by
money, public investment. The sources strongly reaffirm that priority must be given back to public health, and specifically to strengthening primary care.
the first point of contact.
Exactly. The goal has to be building a responsive, integrated primary care service that assures universal coverage. This isn't just about fairness, though it is that.
It's also about cost.
It's the most effective long-term strategy for containing overall healthcare costs. Good primary care prevents minor issues from becoming catastrophic illnesses that end up feeding the expensive, high-end, high-capex private system later on.
So ultimately, the evidence suggests the leadership challenge here in India requires more than just policy tweaks. It's a shift in perspective.
A radical shift, yes. If the high cost of medical education creates a workforce skewed towards serving the wealthy, and if the high cost of hospital real estate forces caregivers to become salespeople, then the core problem isn't just a lack of money.
It's a lack of.
A lack of ethical commitment, perhaps. A lack of disciplined process focused on the public good.
That's a powerful thought to end on.
Indeed. The final critical takeaway from these sources seems to be that this necessary shift requires more than just increased funding budgets. It requires a fundamental change in allegiance.
Allegiance from what to what?
From focusing solely on financial return on investment to focusing on what some traditions might call dharma righteousness, duty, ethical conduct, especially when it comes to the fundamental human right of public health. It implies acting for the public good without being solely attached to short-term political or financial results.
So, upholding public health as the primary duty, even if it means confronting powerful, entrenched, profit-driven models.
That's the provocative suggestion. It's about understanding that the silent neglect of public health is itself a catastrophic action with devastating consequences. Real wisdom, the sources imply, lies in recognizing that connection.
Which demands accountability and a willingness to fundamentally question the priorities of the current system.
Exactly. That seems to be the path forward suggested by this analysis, a radical questioning of these profit-driven models to ensure that economic growth actually translates into human health and survival for everyone.
Thank you. That was a truly deep dive, and thank you for joining us. We hope this knowledge empowers you, our listener, to understand the immense stakes involved in these issues.